Well, good evening there, Dr. Yatros.
Good evening, Dr. Drake. We're getting ready to start here. I thought I would hit the start broadcast button so that everyone can get logged on. We had several hundred people register for this webinar, so hopefully they can all get on here. I've got on the computer beside me, making sure that attendees are seeing what we're seeing.
Get my guitar tuned here, Guy, for that song I'm going to do later. I took guitar in high school. I don't know if I ever told you that story. And the instructor's like playing his little string, and he goes, "Play yours, yours, yours." And he goes, "Listen to mine, now play yours. Do they sound the same?" And I said, "Yeah." He's like, "Oh man, there's one in every class." I was that guy.
Yeah. Well, it might be entertaining. My ringtone's a snoring apnea sound, which my 14-year-old absolutely hates, which makes me desire to never change it. We gotta
do it even more, huh?
Yeah, let me turn that chime off too. I didn't. Where's that on? So I think everybody's logging on here. Let me turn that off so we don't have to listen to that.
Yeah, well, thank you guys for joining us tonight, taking an hour out of your busy weeks and listening to Guy and I talk about side effects. So we got a lot of information for you here. We could probably take every one of these side effects, Guy, and talk about it for an hour if we wanted to, but that's what dentists like to do. They like to beat this stuff, down to the nitty gritty, but we're going to hit it a little bit at a high level, but I think in some ways, Guy, that's better, don't you?
Yeah, we're going to start at a high level, but then we also have kind of I think it's 8 categories that I think are the most common. And it's going to be something we're going to do a little different, which is a interactive webinar, which we haven't done in the past as often. So you get to vote on the subjects we're going to talk about in just a little bit. So we're excited to bring this to you. A lot of you probably know who we are, but if you don't, I'm Dr. Guy Yatros. I'm a dentist along with my partner, Dr. Richard Drake. He and I started Dental Sleep Solutions together. We've been doing this independently for over 20 years. Together over 40 years between us, seeing thousands of patients. We have some of the busiest dental sleep practices in the office and in the country, rather. And we certainly don't know what everything to do. We know a lot of what not to do.
That's how I know.
That's why we're going to be talking about side effects tonight. It's going to be the things we've learned along the way, and we're really excited to share it with you. You will get an hour of CE for this. It'll come into your whatever email you signed up with. So give it 48 hours. If you don't see it, look in your junk folder. Of course, if you can't find it there, we'll give you our contact at the end. We'll also give you some things, some discounts on a few things that we're doing coming up. So stick around for that as well. We have the question and answer opened. We have our customer support team. They're called member support experts. These are our team members that help train dentists all across the country. They're going to be in there answering your questions. Rich and I will be answering the questions. It's a webinar because we have hundreds of people signed up. We can't open up the mics, but type your questions in the Q&A, and we will get to all of them verbally or by typing before the night's over, we promise. There's also a chat. If you just, that's more, we might drop some links to certain things if we bring things up in the chat. We'll also probably drop them in the Q&A. So questions go in the Q&A. And our next webinar, we'll have a slide up for this at the end, is this was we did a survey last time, and this was the thing everybody wanted to talk about. Rich and I have built our practices. I have 3 offices in the Tampa Bay, Braden, and Sarasota area. Rich has 2 in the San Antonio area. How did we do this? How did we go from dentist to doing thousands of devices a year in dental sleep? We did it a lot.
One doctor at a time.
One doctor at a time. We're going to give you 6 specific tips on how to do that. We'll give you probably more, but we're going to give you really the framework for doing that if you want to build this practice. If you register and use this QR code, and I think someone will drop that into the chat box too, the link, you get $20 off on that 1-hour webinar. And that's on, I think,
April 27th.
Yeah, there it is, April 27th. So we'd love to see you there. Again, I think it's by this Friday. You've got to put that in. So we're going to talk about the side effects, and what do you do when this happens? Well, we're not going to answer that right now. We're going to give that as one of the opportunities for you to ask about.
Is there something wrong there, Guy?
Oh, maybe if you want to chew your food a little bit better than others, it might be a little bit of a difficult. But we're going to give you right now the first 7, 8, 10 minutes some pearls that are going to help you get through these challenges. But I think at a high level, if you go into dental sleep thinking, "Wow, I'm doing this because there's no stress," I think some people say that, and we always say it's less stress. You're going to have some stress. There are going to be issues. And if you expect them and you discuss them with your patient ahead of time, you're going to feel this process is going to be much easier. If you think I'm going to give somebody a mandibular advancement device and I'm never going to have any problems, it's going to fit the first time right, the first time, it's always going to work and it's never going to give anybody any problems. I don't know what reality you're living in.
Sign me up for that too, guy.
Yeah, right.
How much does that cost?
Yeah. And I think it has as much to do with your attitude as anything. I mean, whether you think you can or whether you think you can't, you're right. Henry Ford, I think that's a pretty good saying. And I think if you go into it with the attitude, look, we're going to fix this problem. We've seen it before. If things happen, we're going to get you through that. So the 5 pearls Rich and I came up with, and I think, this is not down to the nitty gritty as much as the rest of the presentation, but I think if you'll keep this in the back of your mind and write down these, maybe just make yourself a list. When things happen, take a breath and start by not freaking out. I think I can honestly say, Rich, when we train other dentists, we go and do consulting in their offices. We train all of our members across the country. That we put this number 1 because I think it's the number 1 problem. If you come into your operatory and you say to your patient, "Oh my God, where's all that blood coming from?" They're going to freak out too, and you're going to have a hard time building that relationship back. You've got to just calm down, act like you've seen it before, not minimize the problem, not go, "Oh, it's nothing." Don't tell them it's nothing if it's something to them.
No, but certainly act like this is within the scope of normal.
Right.
Yeah,
absolutely. And I think, what's weird is dentists are pretty good at that because they've had the experience in dentistry. When the root tip breaks off as you're extracting it, or you can't get a good impression, the patients are gagging, you know how to act like, "Hey, this is par for the course. This is what we do." You just got to have that same attitude while you're doing dental sleep. I think informed consent is essential. We do a course, and maybe we'll do that one coming up, on documentation. And why do you do that? And what's the first thing that happens when you have a patient that comes into your office and they're upset about something? "My jaw hurts," or "this thing broke off," or anything. It doesn't matter, crown. And they're upset and they're just like, "You've really screwed up here, doctor," because if you've practiced long enough, you're going to have a patient say that to you. What's one of the first things you do or your team does?
Are you asking me?
Oh yeah, or anybody. As you think about it out there, they can't answer it, but you could type it in the Q&A. A lot of times I go, "Where's the informed consent?" You start grabbing that chart going, "Man, I hope all the paperwork's in order here." Just make sure the paperwork's always in order. And you shouldn't have to think, "Well, I hope we have that on this patient." You should have a system in place where they sign it. And I don't think it should just be, "Hey, don't read this, Mr. Jones, sign it. Here, read this. These are things that can happen. This is a medical procedure, and have that paperwork in place, and feel free to answer the questions. And if they have questions, answer the questions, because they're not your side effects. These are the side effects of treatment that are possible, and they need to be informed of it, and they need to consent to the treatment. And so, that will be a peace of mind for you.
I think that goes along with number 1 there too, Guy, with don't freak out. Right. We've all taken teeth out and things break and nerves get involved, and you're like, "Oh my gosh," you're right. Do we have an informed consent? But I think a lot of this is repetitive in the sense that have systems within place, how you do things, be consistent with how you do it. When you take a tooth out, you do the same kind of thing. You have them sit down, they read the informed consent, and do you have any questions about this? Well, this is no different.
Absolutely. And don't think this is less invasive. I mean, it's not invasive, but it's a medical procedure for people who, have a breathing problem, and it can lead to a lot of problems. So make sure that you have that. And I can tell you, if you're calm and you act like you've seen it before, you got the informed consent, and you say to the patient, this is okay. Usually these things go away with time. I use my knee as an example of this. I have a bad knee. I've had the cartilage removed partially, and I've just kind of gotten used to it. It's not totally healed. I've learned how to deal with it. I've learned, certain. I don't run. I still go elliptically. You learn things. These patients, I get up in the morning, my jaw hurts. Well, sometimes that lasts forever. Sometimes every morning they get up, their jaw's a little sore. It usually doesn't, but they say, at least I'm not snoring anymore, and I feel better. And I put up with the 2 minutes of discomfort that it takes to get it back. And if you're not freaking out, and the patient gets a little time, and lots of times with time, the whole thing goes away. And so, just act like you've seen it before and saying, give them some time. These things usually work themselves out. I think that probably cures more things than anything that we can give to them or do on the device is just let them get used to it. And part of that is
Yeah,
they settle in. Part of it's
that
mental.
reminds me of, when I started doing this, I was seeing people after I delivered the device at 1 week,
Right.
and they had a bunch of these problems. And I remember one day you going, well, you know how you get rid of most of those problems? I go, how? You go, see them at 3 weeks, or 4 weeks. So, I mean, you were right. A lot of those things go away. So if we talk about, hey, some of these things could happen, just realize none of this is going to last forever. If there's a big range of normal, and I usually tell them, Guy, if something keeps you from not wearing this device more than a few nights, then you should call us.
Absolutely.
Yeah. Otherwise.
And that's a little bit of that informed consent. We don't want to spend, like I said, we could talk about each one of these subjects probably for an hour. But that informed consent isn't just getting them to sign the piece of paper. It's letting them know, hey, what to expect. Your jaw's going to be sore a little bit.
That's how we want to be treated.
Right.
When we go see a doctor, we have a procedure done. We want to know what can happen, or what are the things. It's just kind of, the golden rule there.
Absolutely. And, yes, there's other medications. I think NSAIDs are fantastic for inflammation, and you really can speed up. So that we talked about time a moment ago, heals this. Well, NSAID shortens the time that it takes for these things to heal. If you've got muscle discomfort, jaw discomfort, these things can really help. I think my next slide, we may have the slide down the road that tells it, but you can use whatever NSAID. Melexicam's one. I think we have a slide on it or somewhere. There's one that they can have once a day, or you can use your over-the-counter ibuprofens, Advil, that type of thing. Given not just for discomfort, given for their anti-inflammatory properties. So you as dentists should know what the dosages are on those. It can solve a lot. And then it kind of goes with not freaking out too. All these things tied together, but reassure them. I've seen this before. This is going to get better. Most likely, here's a scenario. Here's what to expect. And again, if we have informed consent, and now we're reassuring them this is normal, we're not freaking out. Give it a little bit of time and add some NSAIDs on there if we have to. That's going to solve the vast majority of the problems you're going to run into, maybe other than significant bite changes. So those are our 5 pearls to start with. I think we mentioned before that discussing these ahead of time with the patients, I get them to read the informed consent, and I say you can expect these first 2 things here. Your teeth are going to be sore, and your muscles in your jaw may be sore because it's like a new pair of shoes. You're doing some new exercises at the gym. Expect that, and you very well could have some bite changes. Okay, we're going to do everything that we can to minimize that, but you might have some bite changes, and we can talk about how you minimize that if you want. But those are things I at least verbally discuss with every patient. And then the informed consent, I said, there's a lot of other stuff here that you need to read, and let me know if you have any questions. I don't just say, here's a stack of 15 papers, please sign it. Don't ask me any questions. I think that's part of how you prevent these side effects, is making them be aware that this is part of the process, and that you're open to discussing it. So anything you want to add on that, Rich?
No, I think a good way to do it is just like you said. You don't want to, I don't know what the right way to say it is, put the cart before the horse, but that's not it. You don't want to, you you got to be smart too. If you have a patient who's, what's the word, guy, for the guy that gets sick at everything, you know, every single little thing. I'm drawing a blank here. Yeah, hypochondriac. Thank you. Yeah. So
I was married to one of those. I should have known the answer to that, but go ahead.
If you've got somebody like that, you don't want to put these ideas in his head, you know. But you know, most normal people, and most of our patients are normal. You know, you can say, you know, it's a lot of my patients, Guy, are referred by physicians, you know that, and a lot of them have already tried and failed CPAP. And I say, well, tell me about your CPAP experience, you know? And a lot of times they'll say, you know, it's just not normal to put this mask on your face and have it blow air down your throat. And I said, that's right, it's not. You know, it's only slightly less normal to put a big chunk of plastic in your mouth and hold your jaw forward. You know, we're not used to that either. So you know, we're taking your teeth in this device, and we're gonna hold on to your teeth, but we're gonna try to reposition your lower jaw so we make your airway bigger.
Absolutely. And the informed consent probably should include most of these things on here. This was a poll they did over 10 years ago, the AADSM, and they said to a bunch of dentists practicing dental sleep, saying, give us everything that could possibly be a side effect on here. So we don't have time to go into all these, obviously. We kind of picked some of the ones we felt were the most, I would say, common, and also the ones that people tend to want to talk about. And so here's your opportunity. We have these 8 subjects here, and we're going to do a poll. Which one of these you want to talk about? And we're going to spend the next 45 minutes talking about as many of them as we can. So here's the poll. I think I launched it, hopefully. Yep. So everybody vote. I can't tell which one
you're voting for.
Yeah,
everybody vote. And I'm going to write these down, Guy, when we do that. So these aren't listed here in any particular order, you know, that we have. You've already heard us give you guys a few pearls, so you kind of have an idea of the types of things that are going to happen. And when we looked at the 3 major things, but you know, some of you have done some of this, and you've had some of these things happen. Guy, it looks like so far.
Yeah, I'll stop it. We've got about a little over half, not even half the people voted, but give you 5 more second warning, and I'm going to end this and lose your chance to get to vote. I'm going to end the poll, and I can even share it with everyone. So what does it look like here? Which you got bite changes, and
jaw discomfort.
Yep, jaw discomfort is number 2.
Device breaking, and then device too loose.
Okay, all right, break and then loose. That'll probably get us through the and then if we get to the last one, it would be saliva, right? Okay. All right. We got it, folks. We'll do it. I said it's the first time we've done it this way. Hopefully you'll enjoy this format. I'll minimize that in case we need to come back. So number 1 was bite changes. So let's talk about that. If my mouse works there and clicks where, we got our slide. So look at that.
You were one off. You clicked on the open contacts.
Oh, I did, didn't you? Oh, let me go back. Now look, man. Now we're gonna really. I did. There we go. What I hit? Oh,
there you go.
Yeah, the bite changes. There we go. Hit the wrong one. I had the cool hyperlinks, and my fat fingered mouse didn't hit the right spot. Yeah, I think this is the most common one. This is the one I think that probably most of you all are asking about, because there's, you know, major bite changes, minor bite changes, posterior open bite. That can be kind of disappointing or concerning when that happens. So I think, first of all, what causes this, Rich? I mean, do we know these days? I know there's been a lot of research on it. You can read. I'm not going to read the slide to you here. I know.
I don't think we really know. You know, I think there's a couple of things, Guy. When you grab a hold of somebody's jaw and you start to move it, we create a little bit of inflammation there. There's no doubt about that. And again, that's why NSAIDs work great. We already talked about that. You can get some edema in that joint space. I think too that the pterygoid muscles can shorten. It's unlikely in a normal patient who's going to eat 3 meals a day and chew their food. That's probably not going to be it. I think sometimes, Guy, the teeth say, this is how I fit together. And then sometimes the jaw or the brain says, you know, I don't care how the teeth want to fit together. You know, I get more air when I'm doing this, you know. So I think naturally, we were watching the Tour de France. I remember last summer, my son, he said, look at these guys, Dad. Every time they breathe, they jut their jaw forward, you know? And I think something about our brain just understands that we get more oxygen when we do that. So
Right.
I remember the very first time I saw this guy in my practice, I had made a device for a lady. Work called her away to Brazil. She came back about 2 years later and I said, how are things going? Oh, great. You're wearing your device. Oh, I love that thing. Wear it every day. Are you having any problems? No. And I look in there and what does the guy in Alien say? I give that a sphincter factor of about 9.9, you know, the first time it happened. And I said, can you make your back teeth touch? And she said, are they not touching? And I
That's
handed her a
exactly
mirror
right.
and she goes, oh, wow, I hadn't even noticed. So that's very hard for us as dentists to believe, I think, because I was probably in that camp who wouldn't have believed that. We all have patients who say, you know, that filling's too high and there's nothing there. You check it, but this kind of thing can happen as well. And you know, when you think about you know, when you're moving your jaw forward and then you lay down and your lower jaw is wanting to fall down and back, you're putting pressure on the facial of the upper teeth and on the lingual of the lower teeth. So that has concurrent, you know, those are the forces that are acting because we're trying to hold that jaw in a position that helps keep our airway open. All
Yeah,
of this.
Dr. Lowe did some studies on serial cepts years ago that basically showed that the teeth can move, the whole arch can move, and even the bone can move, and they can have changes in the joint. So all these things can happen to end up with a posterior open bite. The best thing that's happened to help prevent this, and I know the question is what happens when it happens. We're going to get to that in a minute. But what happens, the
How do we
best,
keep it from happening?
just keep it from happening. And we make this AM aligner on almost every one of our patients, and not the old school full wafer. You want to make the AM aligner, you can get these from Airway, or friends at Airway Metrics. You can buy the wafers, you can buy the beads. This device does really two things. You make it at the time of delivery, and it really repositions their jaw into MI, what we used to call CO, when the teeth are already matched together. And the reason I like it just in the front, they can feel their back teeth come together. So this device is going to do two things for the patient. It's physically going to reposition their jaw every morning. So they're going to buy it on this. They put it in. They're going to squeeze for 5 seconds, release, squeeze for 5 seconds, release. I like to tell the patients, you got fluid buildup in your joint, and it's like wringing out a sponge. We need to get that tissue compressed. We need to get the jaw back and squeeze, compress. And I want you to feel your back teeth come together till you can feel it. Then they take it out. Can you feel the back teeth come together? And if you really want to check it, you can get some wax floss and double over once or twice and say, bite down. Can you feel that grabbing in the back? So the two things this device does, number one, is it physically repositions the jaw. Number two, it gets them in a habit of checking their bite daily. So if they actually do this, they're not going to be Rich's patient that comes in going, what do you mean my back teeth aren't coming together? Because to be honest with you, most patients don't notice this. Most of the time when I see a patient has posterior open bite, their dentist pointed it out to them, because I'm usually not their dentist because I don't have dental practice anymore. The patients, believe it or not, rarely notice this. So if you will, we used to not use AM aligners. I mean, we've been doing this 20 years. They weren't around. And this made the biggest difference. If the patient will, in fact, use it, I can tell you, in most cases, it will prevent major posterior open bites. And if the patient comes in and the posterior open bite's there, and you say, are you wearing your AM aligner? Almost always they'll say, you know, I kind of gave up on that thing. Well, at least, not that we're happy about it, but at least it's on them, not on us, you know, that they did that, and that they really kind of didn't do their job. So there's other ways of getting the jaw to go back. I don't think we need to spend a whole lot more time on it. You can have your chin push. You can have little things you chew on in the front, but essentially getting daily repositioning and checking of the device is what we need to do. The question was, and we want to answer that, what happens when you have bite changes? Okay, let's throw things up here. They really have two choices. Go ahead.
It goes back to those pearls, Guy. You don't have to necessarily freak out. Stay calm, you know, ask some questions.
Absolutely. And really the patient has two choices. Number one is if this bothers you and you want it corrected. And listen, don't make it their problem because it bothers you as a dentist. That's the biggest thing that happens is you go in there and you freak out. Oh my God, the back teeth aren't hitting. You're going to destroy your front teeth. That almost always is not true. That's a double negative, I think, there, but seldom is that true. I have seen hundreds of patients with posterior open bites over the years. Don't see as many now that we have the AM aligners. And many of these people are functioning. They're not breaking their front teeth. They're still obese. They're eating just fine. They're getting along just great. And because they're not mashing those teeth together, you would think they would just destroy their front teeth. Everything in your soul will make you think that these people are just going to destroy everything that they have. And it really doesn't happen. So the first question is, Mr. Jones, does this bother you? Your teeth aren't hitting together. No, it doesn't. Well, then we want to
What's the next question they usually ask, Guy?
Are you going to take my device from it?
Well, should it bother? Yeah. Or, you're not going to take my dental device, are you?
That's the number one. The one they start thinking you're going to take their device from it and say no. So they really have two choices. One is they live with it, and it's a side effect. You can continue to try to work with the AM aligner and get it to go back, or we decide we're going to deal with the posterior open bite. And in my opinion, the only way to deal with that is to discontinue therapy. It is the first step of fixing that problem. Okay, when you bring that up, if it was bothering them, about 90% of the people it was bothering say, no, it does not bother me that bad. I'll continue wearing my device. That's my experience, especially if you don't freak out and you're reassuring them. It's their choice. But if it is bothering them enough that they want to fix it, say, we cannot continue to pull your jaw forward while getting your teeth to go back. It doesn't work that way. So you're going to have to choose, not me.
Are you okay with going back to CPAP?
Right, because you got to not treating your airway. You do not say quit wearing your device and let's see what happens. And then they die of a heart attack in their sleep. That's not serving anybody any good. Or they fall asleep the next morning and kill a busload of kids going to work. You don't want that happening. So look, if the only way to doing this is not wearing your device and choosing another therapy. Now, if they choose on their own to do nothing, that does happen. That's up to them. And then depending on how long it's been. If it's not been that long, and even if it's been a while, sometimes, most of the time, if they quit wearing the device, it will go back many times. Now you can accentuate that by having them wear their AM aligners, making, NTI type devices maybe to help the jaw seat more, but just saying, don't wear the device anymore, wear your CPAP, and it will go back. At some period of time, if it does not go back, and I would say some period of time in my book needs to be at least 3 or 4 months before I'm going to give up on this completely.
I was going to say at least 6 months.
Yeah,
Probably
6 months.
6 months to a year.
Yeah, I mean, just give it some time. The forces that put those teeth in that position to start with will put it right back oftentimes. If it doesn't, then you've got to treat it like anybody else that came in your office with malocclusion. You've got malocclusion. How do you want to fix this? They've got all crown and bridge in their mouth, and they need new crown and bridge. You can do it restoratively. You can do it orthodontically. You can do it with equilibrations. Put your dentist hat on and figure out how you're going to fix this. Do not apologize. Do not feel like you did something wrong. Say you can be sorry that they're in the situation, but not freaking out. This is a side effect of treatment if you explain it ahead of time. And in most cases, if they would have worn their AM aligner, they wouldn't have gotten here. So very common problem. Prevention's everything. I don't think I have a slide for single tooth movement, but for single tooth movement, the biggest thing we can do there is prevent that from happening. Your device design has a lot to do with that. So the hard acrylics that wrap all the teeth, I'm going to have less of that. The rubbery, soft liners are going to be more prone to tooth movement. Not wrapping the distal of the back molar, especially if you put a ball clasp between the second and first molar, you're going to have more single tooth movement. So device design can happen. Single tooth movement, we rarely do anything about.
Well, a lot of times it's as simple as adjusting the device. If this tooth is pushing hard, and usually they're going to say, man, this tooth kind of hurts right here. And remember also that it's not always the tooth that's moving. Sometimes it's because of the way it bites. It's, the top one that the device is too tight on might be, the problem, but the bottom one, might be the one that's hurting because the way that their bite is. So you really got to use your brain on that. And I think you really have to be careful if you're going to restore these people with a lot of crown and bridge.
Wait 6 months. I'm with you.
I would say, man, I would probably even wait a year before I did something like that.
That goes back to the time thing. After a year, they may go, you know what? This doesn't bother me as bad as I thought it did. And they go back and they're trying the CPAP in the meantime. They're going, well, I really hate this CPAP. You know what? This bite changed you know, isn't so bad. Let's like my knee. I don't want to put a piece of titanium in there right now. One of the questions that came up is, what if they don't have a CPAP or they have to pay out of pocket? You've got to get your dentist hat off here. You're doing a medical procedure. There's side effects that happen. Their choices are 1 and 2 here, folks. Continue therapy and live with the side effect. Quit therapy that you provide and find another therapy, or go without treatment, which we don't recommend, but it's their choice. And that's up to them what they do. We didn't cause the apnea. We didn't cause the posterior open bite. It's a side effect of treatment, and you need to be compassionate, but you don't need to put it on your shoulders. It's up to them what they do here. And once you take that burden off of you and put it on them, they have to make the choices. Here's where we are. Here's your choices. I'll support you on whatever you do it, but you don't need to apologize or feel guilty about it.
Agree, Guy. Another question talks about, well, you know, maybe patients don't have a spare CPAP laying around or something like that.
Right.
And that, you know, that's true. You know, a lot of my patients have already tried and failed CPAP, but you know, that comes back to, I think, your mindset about how important it is to treat this disease. So if that guy has an AHI of 5.2 and he desats to 93%, none of this is that big a deal.
Right.
So, man, let's see if it goes back. You know, maybe we'll work back. Maybe we'll use your bite tabs or your AM aligner. We'll do something like that and we'll get it. You know, but if the guy has an AHI of 52 and he desats to 73% and spends 19% of the night below 90%, not treating this is not an option. Mm-hmm. We need to get you a CPAP. You know, you didn't try one because you wanted to try the dental device. Well, the dental device is working well. It's just like I tell patients all the time. Guy said this morning. Don't throw your CPAP away, because your dental device is going to work and you're going to do great with it. But 2 or 3 years from now, you're going to go, you know, I don't think this thing's working quite the way it used to. You know, I think our mind, something about human nature and our mind. So a lot of times you have patients who wear CPAP a few nights a week and they wear their dental device some nights a week. But again, it goes back to the mindset that the more severe your disease is, the more you have to treat this. You know, and that's when, as I teach my assistants how to do this, Guy, I'm always saying, you know, we're going to do a follow-up. I said, well, how bad is this sleep apnea? Oh, it's really severe. Okay, then this is all very, very important.
Yeah. Again, I think what I was trying to say was to address that question. You know, yes, if they can't afford a CPAP, I'm not saying it's not our problem, but it really isn't. I mean, we can try to help them with them. We can refer them to other people, but really, you know, if they went to the cardiologist and, you know, they needed the AFib surgery didn't work, now they need a pacemaker. Well, it is what it is. You know, it's a medical procedure. They don't go back to the cardiologist at the AFib and say, well, I can't afford the pacemaker. Well, sorry, you know, it's you know, let's work with the doctor that can help you. It's we're just not used to that as dentists. We're kind of putting the predictability of treatment on ourselves when we shouldn't.
Well, a lot of this too goes back to, Guy, you know, dentists aren't very good at picking up the phone and calling physicians. Yeah. They're not very good at writing letters, you know, and that's partly why we designed DS3 the way that we did. You know, I put out, what did we figure, Guy? 9,600 letters went out of my office last year. And it was a relatively slow year compared to the year before because of the pandemic. So the more you involve those physicians, the more they get to realize, hey, this dentist actually understands how important it is to treat the sleep apnea. I'm trying to get me involved now with ordering the patient an AutoPAP or, you know, doing something. We have our patients, Guy, when they don't like their CPAP and they're going to get rid of it, but they've already paid for it, we have them bring it into us. And we recycle some of those things. You know, we hire a company that actually cleans them and they do it. And then we hire this 16-year-old kid that figures out how to reset the pressure on all of them. And, you know, we get their physician involved. So there's a lot of ways to do that show that you care, you know, as the patient, but don't apologize. Like Guy's saying, it's not my fault that these things happen. We're going to do everything that we can to manage this disease the best way that we can.
All right, let's move on to the second topic, jaw pain. This is a pretty involved discussion. Number one is because it's a broad discussion. What does jaw pain really mean? And I think, it's in a strange way. I enjoy the procedure of figuring out what's wrong with people with jaw pain. It's kind of a, it's a, it's a, it's a, an exercise of your brain. It's kind of like solving a mystery in some ways. And you just got to kind of go down the checklist and start asking questions to determine what do we mean by jaw pain. And so we got to figure out, is it in the joint, or is it in the muscle, or is it in both? That's one of the first questions we need to decide, because jaw pain itself doesn't mean the same thing. I would ask, as you're looking at this at home, which one of these do you think are joint and which one do you think is muscle? And this is not the only test you need to do, but just say, hey, where does it hurt? And if they take one finger and they point it towards the joint, it's probably the joint that's hurting. If they take their hand and touch the whole side of their face, like the one on the right side of your screen, it's more likely the muscle that they're talking about. And if you don't know and you're trying to make a wager, muscle discomfort is far more prevalent than the joint discomfort. So we try to figure that out. And then we want to know, when is it hurting them? Because we are assuming the biggest problem, I think, people, when they're trying to figure out what's going on here, they assume the device is causing this discomfort. And that's not always the case. Sometimes it's when they take the device out in the morning, the repositioner is causing the discomfort, or the bite change that they're experiencing is causing the comfort. So when does your jaw hurt? Well, they say, I feel fine until I get up in the morning and I take this thing out and then it hurts. Well, does it take it out when you bring your teeth together? No, it's when I put that little thing in the morning that causes it to hurt. So we got to figure out, when is it hurting, as well as to whether it's the device that's causing this, is it clenching that's causing this, or waking up halfway through the night with it, or they're hurting further throughout the day, and do a little bit of detective work. If it's the AM aligner, then we want to be less aggressive with the AM aligner. Have them wait an hour or two. I saw someone put in, give me 15 or 20 minutes and I put my AM aligner in. Sometimes I'll have patients wait an hour and a half, go to work, and then put your AM aligner. Do it very gently if that's what's causing the discomfort. They'll say, yeah, when I put it in, that's when I start noticing it. The patient's not going to come in and go, my jaw hurts, and it's because I take out my device in the morning and then I put my AM aligner, and that's what's causing my jaw to hurt. They're just going to say my jaw's hurting. They haven't really thought about when it hurts and why. And then, is it on both sides or is it on one side? And so this is kind of the detective work you need to figure out to understand when they say I have jaw pain. That could certainly mean a lot. And then, really, how long has it been there, and how much does it hurt? I'll quote our buddy Jamison Spencer. I like what he says. How's it on a 0 to 10 scale? 10 being burned alive is what he always says. Because if not, everybody puts it's a 10. And
are you sure it's 10?
Yeah, are you sure it's a 10? You really feel like you're being burned alive? We better call 911. You really figure out, how long has it been there? Has it been? Is it just? Did it start from the day one? Did it start? Did you do great for a while and then it happened? So trying to do some detective work on that as well. And so,
Guy, we had a guy just today whose jaw is really hurting, and he called his physician. His physician called me and said, hey, we need to help this guy with his jaw. So I called him. His name's Ed, and I said, Ed, what's going on? Oh, my jaw just started hurting. Well, what in the world makes you think it's your dental device? Well, how long have you been wearing your dental device? 9 years. And your jaw just started hurting. Is it possible it has to do with something else? Yeah, it is. So again, don't assume that it's always us and our dental device. People can pull a muscle chewing beef jerky, just like they can pull a muscle raking leaves and, taking out the trash. I mean,
they could have gone to the dentist and had a bunch of the deep root planing and strained their jaw.
Had to keep their mouth open for 2 hours.
I've had that happen. They come in and they go, oh, well, did you have anything done? Well, I had, 4 quadrants and RPNC yesterday. Well, was your mouth open? Yeah, for 4 hours. Well, geez, no wonder your jaw. So they just don't think of it that way. You've got to be the detective here. And so what your detective work has to calm down and figure out what's the cause. And really, the 2 on the top are the most common. It's just, and it goes back to the informed consent, not them signing it, but informing them that, hey, your jaw's going to be a little sore. And so if it's so sore you can't wear the devices, what I tell them, then call me. If not, put up with it, to live with it. It's going to get better most of the time. And you'll get far less calls than if you say you're going to love this thing and have no problems. So we do a course on what we call fast track calibrations. If you're interested in that, we'll do that again in the future. It's actually, we're talking about at our symposium. And what we do now is we don't go near as far forward to start with, because we have a way of testing our patient's device at multiple positions from a conservative beginning of maybe 30% advancement, maybe 40. We help consulting, one of the number one problems is people at 60, 70, 80% of maximum protrusion, or they advance them out there quickly. And that's by far one of the reasons. Now, I'll also say that not going far enough can cause problems, because if people still have an apnea, they're snoring, they're clenching, and they got this new device in there and they're clenching a little bit more. Sometimes advancing them more forward will actually help this discomfort too. So if it's on both sides, it may be too far, too fast, or in some cases, they've not gone far enough. And it's due to, again, the newness of stretching. We've already addressed the AM aligner. I think the AM aligner, I put it up near the top because that happens a lot. And you've got to, tell the patient not get, they're scared to death the bite's going to change. And they get up in the morning and clench down really hard on that, and it shoves the jaw back. It can really make a discomfort. And then again, asymmetry. If it's one side, we're going to see that more than the other. And then, the other one I haven't talked about is they take the device out in the morning and they say it starts hurting afterwards. Maybe we've deprogrammed their jaw and now they're hitting on a tooth prematurely or something like that, that can cause the problem. So it can be the bite itself, or it can be the device not hitting well. So, I mean, those are what we got to come down to. The too far, too fast. This is Rich's first patient where he advanced him on the day one here. But okay, this might be too far if this was day one of treatment here, we would say. Unilateral, I think of
It took that guy about 2 years to get out that far.
Yeah, that is Rich's patient, by the way.
He did not want to wear CPAP. So that's what a motivated patient will do.
Right.
When you say, hey, you just always go back and wear CPAP, and he's like, nope. So you want to answer any of these other TMJ internal derangement now, Guy?
Oh, sure.
There's, doing MRI.
I think that's, I'll answer that one. I rarely. I think you can figure out what's going on most of the time through your exam. I think if you're going to do sleep, you probably need to have some background in TMD. We could, they teach at the Pank Institute where I taught, we do a 5-day TMD course. So we can't do that in the next 10 minutes. But I would say that you can figure out most of the time what's going on without an MRI. It's rare, if ever, that we would have to do that. So virtually the TMRI influence factor.
Yeah, the other thing too, saliva. We're going to get to that, with the saliva, because it can be an issue. And again, it comes back to how bad is the guy's sleep apnea? Can he wear CPAP? Will he wear CPAP? How much does, has he tried to wear this? So I tried to wear it, every bit of 3, nights, 3 weeks, 3 months. So a lot of that, you have to be careful about that stuff. And, some people just can't wear their dental devices, and it's a sad thing. But again, in your informed consent, that's one of the things that should be in there, too much saliva or not enough saliva. And
we can probably answer that at the end too, if someone wants because that was I think the last one on the list. So
that won't take
we'll be happy to stay on a little bit later to stick with the schedule. Someone typed in they agree with the MRI, but then also someone typed in a lot of TMD, especially with ladies. Not that we're picking on the ladies, but they tend to have upper airway resistance. And yes, the TMD is associated with it. And the good news is when you treat their airway, it often improves. And I think we should stop and make sure we make this point, that most jaw problems, or at least TMD problems, let's say, which are the same, one and the same, are made better with dental devices. We don't usually make those worse. We oftentimes make them better. So don't let TMD scare you from doing this, because in general, it's going to make them better. I do want to mention, we won't go into everything on this slide. You can read those yourself. But when it's one side and not both sides, we tend to think there's something asymmetrical. either the device is hitting wrong, their bite's off a little bit, they had a deflection or deviation we didn't notice, or the device is made off to one side, like that. You took the bite wrong. Some things like that. I think my next slide.
Or the patient adjusted one side
Right.
forward and the other side back, or they put the wrong rubber bands on,
Something
you know,
like
one
this.
side
Yeah.
or the other. So you really got to put your thinking cap on when you look at this stuff. You know, I would say that most of you already know most of this stuff. You just got to calm down, think about it, take a minute, ask some questions, you know, go through and just kind of use your brain as you do this. I like to say, guy, with the unilateral pain, I always say the side that's hitting is the side that's hurting. So typically, you know, that side, if you had a herpes, for example, and it was flat in the back and that right side's hitting, you know, you can shave that down. I'm happy to do that. I tell patients a lot of times, hold that side, take it out. You got a nail file laying around, just take a heavy duty flat nail file and smooth that down. You know, I really engage my patients in doing a lot of this stuff. Only one time, guy, did I have to make a new device because the guy was a wannabe dentist and got his Dremel out and went to town with it and actually ruined it. You got to be careful when you do that. The other thing I'll add with unilateral pain is it's the side that's back too far.
Uh-huh.
So almost always, you know, it's either the side that's hitting or it's the side that's back too far. So a lot of that goes back to the midline. You know, we think, I like the way you worded that, guy. Something's out of whack. Sometimes it's our device, but sometimes it's the you know, articular eminence of the maxilla is different. So as a patient moves forward and they're following that, their jaws naturally going to do, you know, something like that because that condyle sliding down there. So again, put your thinking cap on.
And I don't want to keep going back to the 5 pearls, but yes, we want to fix this asymmetry. But what happens if we don't? And the patient's motivated enough, and this is solving their problem. And you know, if I put a pebble in your shoe, and somehow you had to wear that rock in your shoe for the rest of your life to solve some problem, could you get used to it? Yeah, you wouldn't like it. You'd walk with a limp. But you'd get used to it over time. And people just adapt to these things. If you don't freak out, you reassure them, and they're motivated to treat their sleep disordered breathing. Unilateral muscle or joint pain, I'm going to try to address because I do think something's off. The bilateral discomfort, I'm probably a little more inclined to just give time to, because it's not likely something as likely that's something off. So just make sure everything's hitting evenly. Muscle pain is by far the most common, and you know, by the way, it's the most painful. I mean, we think, oh, the joint is what hurts people. In general, the muscles can be very painful. So when we look, at muscle discomfort, most common is probably the masseter. They'll point right here and say it hurts, and it's kind of on the insertion or attachments. You know, the tendons of the masseter, not right in the middle. It's, you know, right at the angle of the mandible. They're clenching. That may be an indication to move them more forward. But just giving it time and NSAIDs. There's the slide I was going to mention. I like some Lexicam if we're going to give it to them, because it's once a day. It says time released. I don't know, mentally they're taking a medication. I'm afraid if I put them on ibuprofen, they might just do that for the rest of their lives or something too. And it'll really help that inflammation. So that masseter discomfort, most of the time, is going to go away with time. And as you start advancing and getting their airway more open, they'll clench less. We might consider adding a deprogrammer that can help, where it just hits in the front. That does several things. It turns down the amount that you can actually clench because the fulcrum's forward, and there's a lot of evidence to show it decreases the muscle fibers that are able to be fired when you only hit in the front. Be careful if they have a joint problem, because if it's not a muscle problem but it's really a joint problem, and you only hit here in the front and there's no back teeth to hit, then you're going to do what we call load the joint. So I personally don't do this. I had an associate that was doing it for a while, but these people are really clenching a lot. Botox has really done really well with them. And I know we refer to a dentist in town that does that. I just don't want to go through the cost of having it around if I'm not using it every day. But it can work really well. And then other things you can look at are, you know, palliative things, stretching, massage, moist heat. Most of those we don't do. Most of the time it's NSAIDs, time, reassurance, and occasionally a deprogrammer we put on there. If we got really carried away and opened their bite up too much, maybe that can help. And then discontinuing for a period of time too, let that completely heal. If you're a little bit forward, back it back up, and
Yes,
reinsert it.
start back a little more.
Start over again. And it's amazing. They had the problem before, and once it goes completely away, it's like going to the gym. I had a strained tricep a few years ago, and I kept going to the gym and it just wouldn't heal. Finally, I'm like, I've got to quit. I quit for 3 or 4 weeks and haven't had trouble, since then. But until I gave it time to rest, it just didn't heal. So just consider, when it's muscle pain, you just tell the patient, yeah, that's, not to minimize it. I know it's painful because muscle pain can be extremely painful, but it's very common. I've seen it before, and time usually heals these things. I mean, you're not going to be like this forever because it's a muscle. Your muscle's not going to stay sore forever. Okay. So we just got to manage that discomfort. And most jaw pain is muscle pain that we actually see. And
several people have commented, Guy, that TMD and sleep apnea just kind of go together. I mean, they really do. And here when we started doing this 20 years ago, Guy, the powers that be said, "Oh my gosh, you can't make a dental device on somebody that has TMD, or TMJ problems." And talking about 180-degree swap there. Now we know that we
right.
We fix a lot of those problems with it, and again, a lot of this comes back to document what's there before you start. If they open, click, close, click, open, click, close, click on both sides, just write it down. I mean, you don't have to spend a long time doing that stuff. Put your hands on there, feel, listen. You can use a stethoscope if you want. You can do that. I can't tell you how many times people say, my jaw's kind of popping now and it didn't used to. Well, here it says you used to.
Right.
And sometimes we can actually take a non-reducing disc and recapture it when we put it.
That was one of the questions. I was just going to say that. Yes, if it's early click, early reducing. So in other words, when you don't have to open that wide, we move the jaw a little forward, we recapture that disc. We're actually helping that jaw, that TMJ. It's in a better jaw
relationship,
fossa relationship. And we could talk about how that's maybe the type of patient that occasionally will have a posterior open bite or unilateral change on one side when that disc decides not to slip off one day, which is a good thing for the joint, maybe not so good for the bite. Having an informed consent on that is important. Most of the time, those reduce and unreduce back and forth as long as the patient lives. It's rare that they recapture it and it doesn't go back, but it can happen. So I hope that's helpful. I don't think you have to go out and take a mini residency on TMJ to do sleep. I do think learning as much as you can about it along the way is important. And I do think if you just don't freak out and you reassure the patients, almost every well, let me knock on wood, every jaw problem I've ever seen on my patients have gotten better either by wearing their device continually and us just managing them, or they quit wearing the device and they move on to another treatment. They go back to where they were before. It's not become a permanent problem with any of my patients down the road. They quit wearing the device. Well, sorry, it's not an option for you. Let's move on to CPAP, and it goes away. So don't freak out like, oh my God, I've caused this person a jaw problem that's never gonna get better. That's I would say not impossible, but it's certainly not very common. All right, I think the next one was broken devices. This one should be fairly quickly, so we might be able to get back into the saliva one too, which was the third one, or loose was the next one. So
we dealt with this twice today, Guy.
Okay. And I should probably update these slides. I did this here. I could talk about which device is there. And this is kind of an old slide we have here. But number one on that, I don't have a device here with me. I usually do. Do I have one?
Here it is.
Yeah.
The device sits like that.
I got one here. Yeah.
Yeah. Show me how you brush it.
Yeah. And they take it and they hold it like this. And they squeeze it every time they're cleaning it. Squeeze. That's the number one reason they break in the front. Took me years to figure that out. So don't.
I told you that a long time ago, Guy.
Yes. So that actually I think it might have been you, but someone told me that. But don't squeeze it. And then if they're continuing to break things, you can move their jaw, the force forward. You think about a pair of pliers. Here is way less pressure than on the back part of the pliers. You're going to put way more force on your molars than you can on your front, assuming if they don't have TMJ problems that only hit it in the front. They're not going to break most devices if it just hits in the front, because the amount of force they can generate there is so much less, and theoretically they'll fire less muscle fibers by doing so. You can add reinforcements, and then what I should have added here is you can pick a device ahead of time. It says switch device, but I should have let you know some that are out there. We can talk about some of our friends. One of them, Whole U, makes a really good devices that are metal. They're EF series, are all metal. You can make those. The Somnus now has the new Evo. I think we did a webinar with them not too long ago. I just made one of those today for this lady, Rich. She has implants. She broke down a bit down on the George gauge. My assistant was measuring range of motion. She broke 2 George gauges. Two George gauges while we're trying to take the bite. I'm like, man, we need something strong here. And we made her an Evo is Prosomnus' new material that can really flex and move. And then our friends at Panthera, they're DSAD, and then they have a new dorsal coming out too that's really cool. It's made out of that printed 3D material. Those devices are pretty unbreakable for the most part. Am I forgetting any as far as that goes?
Well, devices, we can't make anything that some patients can't destroy.
Right.
So, normal wear and tear, people get 2 to 3 years out of most dental devices. I've had EMAs last 10 years. I've had, very top of the line, high dollar devices that you've mentioned last a year. But that's kind of like the 115-year-old guy that says, man, I smoked a pack of cigarettes every day and, drink half a bottle of scotch. Look at me, I'm still alive. And it kind of begs the question, wow, I wonder how long you would have lived if you hadn't done that. So, a lot of times you don't know, but, the other thing too, I wanted to say about that guy is we have what we call our pet attack fee. We make a lot of dental devices in my office. We're getting close to making 100 a month. And I will tell you, not a single month goes by where we don't have a dog or a cat or some kind of pet that's chewed up a device. Right. And we actually call it our pet attack fee, and we charge $995 for it, and it's even in our informed consent now. We even put it in there. So
pet attack fee. I'll write that down. I like it. That's funny. I learned something. Great.
All right. Too loose, Guy?
Yeah, I think we got time to do that. And then we'll answer some more questions. If somebody wants to talk about anything else after 9, we can. This was pretty quick too, but it's ever so important. I think pretty obviously you can adjust ball clasp if that's the type of device that you have, but it took me forever to find an instrument that adjusts these well. So if you have those old spoon excavators still in your armamentarium, great device to get behind those, turn it, and it makes it it makes it really easy to adjust those. Your pliers can't work real well for that. You can reline the device. I think it's pretty obvious, especially if it's all acrylic. But also understand if they have flex material in part of the device, like this one here is showing, you can grind that flex material out in one spot and add hard acrylic. Not the prettiest thing, but you can do that. So of course, acrylic reline. But I think the one pearl that we want to give you here is this will work with the majority of the devices, as we call it, the heat and squeeze. So to get my device out of my pocket here again, you take the device with a heat, you use a heat gun. I prefer just some pretty hot water. Take the device, dip one arch down at a time. So if it was this way, we dip. If that was too loose, I'd dip this side down in the hot water, hold it in there from 5 seconds to 20 seconds, depending on the heat of the water. Then I have cold water running, as cold as it gets here in Florida, tap water in the sink, and I take it out and I just squeeze it like this as tight as I can without hopefully breaking the device, and run under the cold water. It will bend the buccal and lingual together, and you will be extremely surprised at how tight that can make a loose device. Then you go around and do the other side too, and that can solve whether it's got flex material, solid acrylic, whatever the material is. This DSAD type material can work really well by doing that. Also, while we're on the subject, if it's too tight, you can loosen it the same way. Heat it up, put it in the mouth, take it in and out a few times. And then last, so there's the heat and squeeze. I forgot I had the slide in there. Just squeeze the thing together. It takes a little bit of getting used to. I had an associate who was a female, little female. Sometimes she'd have me come in and do it. Maybe she's too afraid to do it or not quite strong enough, but that works.
Be careful, but be careful. If you got an EMA,
yeah,
and you get it too hot, you know, you can squeeze that whole thing together and ruin the thing too. So, you know, again, use your brain. But I love this plier too, guy.
Yeah, this Hilliard pliers. Get the red label one. And I think I have a close-up of it here, do I? Yeah. You can see, I got my picture holding it up. You can see you heat up this part here, showing that, yep. And then you're going to put a dimple by squeezing it. This works fantastic for EMAs, but it'll even work on some of your other thicker acrylic devices. You heat that up, you put it in the interproximal, right in the proximal between like the molars or the premolars, and then I'll show you on the inside. It makes a little dimple. Just makes like a little ball class. Now it's going to put a little hole on the outside. Let the patient know it's going to look a little ugly out there. And if it's hard on these because these aren't acrylic, but if it was EMA and it bothered them, you could fill that in. I usually don't. And you go around and just maybe make one over here too, where it is on the inlingual, and you can really tighten up a device. I've even done these on a device that looks like this, a acrylic device with flex liner in it. It makes a pretty big hole in there, but certainly beats sending it back to the lab and you end up getting undercuts like that. And then you can do this on the same kind of thing on the model. You can, if you have the model there, you can grind an undercut in one way or another, and then heat the device up in hot water, seat it back on the model, and try to squeeze it in to that undercut depending on the thickness of the device. And so those are some really good ways to keep your devices from being loose. And that's a common thing. I guess going back, you can also use material that is adjustable. Thermacryl, I do in all my taps. And then some labs like Dynaflex Lab does what they call AccuFit, which is a type of thermacryl. They offer that in all their devices. It's kind of an ugly material. Over time, it gets stained over time, so it's not as nice as some of the devices.
But we can always make it fit.
We can always make it fit tighter or looser.
We make a fair number of EMAs with thermacryl in them as well. So
absolutely.
I'm going to add one thing to the reline thing, guy.
Sure,
when you do it with acrylic, you saw the picture in there. I like to use the red liquid. You know, if we've got an EMA that's too loose, my first choice is to put some little dimples on the model, put the device on the model, say the lower's too loose, and then we just pour that really hot water over it, and be careful you don't burn yourself. And you can take almost like the back end of that same kind of spoon excavator and push it in, while you're doing that. That can work. But to reline it, I love to use the different color liquid with the acrylic because it stands out, and it's easier to see what's there and what isn't there.
Very good point. All right, well, we're going to answer. There's a few more Q&As coming in. We'll do that. I got a little short video, and then we'll talk about what some next steps are here. I think we'll go ahead and play this. I'll play a little bit of it here for you. Hope you can hear it. Just, you got to kind of get used to being in medicine here, folks. Medicine, medications. Jeff Foxworthy points out that lots of them have side effects here.
There's so many medicines. They got this prescription stuff that they advertise on TV, and I swear, half the time, the side effects are 50 times worse than what the medicine cures.
This is not new.
Try new Floraflor. For itchy, watery eyes, it's Floraflor. Side effects may include nausea, vomiting, water weight gain, lower back pain, receding hairline, eczema, seborrheic psoriasis, itching, chafing clothing, liver spots, blood clots, ringworm, excessive body odor, uneven tire wear, diarrhea, gonorrhea, diarrhea.
You get the idea. You get the idea. Bite changes are not that big a deal. All this stuff is self-limiting. Go back to those pearls. If you need those slides and you didn't have it, let us know. We can send you those 5 pearls if you didn't write those down. Just act like you've done it before. Don't freak out. I can just tell you that the attitude is everything. You act like it's okay. The patient will see that. If you panic, they're going to see it as well. If you want to learn more about what we do, we teach and I'll be teaching this next one, a a 4-day course. I'm sorry, 5-hour course, not 4-day. 2-hour course. We're doing it. I'm sorry, 2-day, 2.5 hours, 5-hour course next Monday and Tuesday. It's a small group, and it's not a webinar like this. It's a virtual meeting. So we'll be able to talk to each other. We'll be able to see each other. We limit it to about 30 people. You get some really cool things if you sign up tonight, or I think within the next 48 hours or something like that, if the code's good for, someone can type it in the chat box. You get a free home sleep test. It's the coolest thing we use now with most of our patients. It's called a Night Owl Mini. It's worth $97. You get our Rich and I spent hours on these ebooks. They're called Demystifying Sleep Tests. Tell you everything you want to know about sleep tests and how it pertains to dental sleep. And then that Fast Track Calibrations, the book tells you how we use this Night Owl Mini to calibrate our devices. You get that for free. And I think I can't see how much the course normally is and what this discount code, because it's $100 off if you use this QR code, and I think someone's dropping it in there. So that's next Monday and Tuesday from 7 to 9:30 Eastern. And I hope to see you there. Go ahead and sign up soon, and you can. I guess the first 15 people only get that Night Owl. So that's that. And if you go to that, you get to come to this one for free. Lisa Hurt has got a vast knowledge in dental sleep medicine. In billing, and as well as dental sleep medicine billing. You can come to it independently for just $99, but it's a 3-hour course. I think we end up giving about 4 hours of CE for that, because it goes close to 4 hours on, where's the date? Is it on there? I think my controls are covering it up. May 7th, does it say? Yeah, May 7th, 1 to 4. You'll learn a lot, you or your team. These are recorded, by the way, both of these are, and you'll have access to the recording for a month. So if you attend, you can share it with your team, or if your team attends this one, they can come back and you can watch it with them. So basically your whole team can come to these courses. And I can tell you the best thing that's happened as COVID has devastated lots of us, this virtual training, the most common thing I get from people who attend this are, because it's different. We can talk to each other. It's like, wow, that was just like being in person, but I didn't have to leave my house and spend $1,500 to take a sleep course. That 5-hour sleep course, we also give you about an additional 5 hours of resources towards other things that you can use, videos and so forth. So you're going to have everything you need to get started. You can type in consult if you're interested in any of these. You can scan the QR code to lock in that with yourself. You also get a starter kit if you come to the course next week. Includes a temporary device, posters, everything, things you need to get started in dental sleep medicine. So pretty good deal. Love to see you there. Our symposium.
Yeah, I want to give you a plug on that too, Guy. If you haven't heard Guy talk about that, he's just fantastic at motivating you and your staff. And I'm going to tell you right now, you're not going to learn how to do this in 5 hours, but you're going to learn how to get started doing it. And I hired a new employee this week, Guy, and I told her, I asked her, how long do you think it's going to take you to learn all this stuff? And she said, oh, like a month. And everybody laughed, who was there, because it was all of our staff there. And I said, we went around the room and everybody said, it takes about a year. And you think, holy cow. Is this really that complicated? And it's not really that complicated. Guy does such a wonderful job of making it easy to understand. But it's also, I keep telling Guy our theme song needs to be the Ghostbusters song, because, it's who you're going to call. I love that thing, because when Guy and I started this, we didn't have anybody to call.
Right. No,
we didn't know. So we had to invent the wheel, so to speak, when we did it. And you don't have to do that anymore.
And I do want to emphasize too, it's interactive again. You'll be able to ask your questions live, and you will be able to get started. Why do we call it the GPS course? People ask. It's because dental sleep isn't difficult. It's complex. There's just like a lot of little things you got to put together. So we give you all the tools by this course to navigate dental sleep. We give you a roadmap for success, and that's why we call it the GPS course. Hope to see you there. I think it's the best. I'm confident it's the best deal going for dental sleep medicine education, when you certainly with the $295 price. And then our symposium's this Friday, and we're doing it virtually this year for obvious reasons, but it's really a fantastic deal too, because we've got some really great speakers. A couple we've been trying to get for years. Dr. Bradley Bale, who's going to talk about how the
Heart
systemic health.
attack. Yeah, heart
He
attack.
wrote the book, Beat the Heart Attack Gene. I've been trying to get him to come. I don't know if you knew that, Rich, for 3 or 4 years since I heard him speak. Every year he usually takes vacation and when we have this meeting, and he's really hard to book, but because it was virtual, we were able to get him to show up. And then Sharon Moore is going to talk about kids. She wrote the book,
Sleep wrecked kids.
Sleep wrecked kids. We want to get her to come, but she lives in Australia because it's virtual. She's going to be able to attend. It's up to 13 hours of CE, and you can watch this live or on demand. Our premium package includes some swag with Sharon's book, Night Owl. You get those ebooks we just talked about and several other things. And your team, several of your team get to come and get CE for the low price. And I think if you'll scan that code or type in symposium, we'll get $50 off for the premium attendance. So if you can't be there April 9th, 1 to 4, that's the live Q&A will be that day, but you'll still get just as much out of it. So go ahead and consider signing up. We've got Rich and I are talking. I'm talking about fast track. Rich, I've looked at your PowerPoint, man. He's talking about the Department of Transportation and how it affects what we're doing and sleep. I'm really excited to hear yours as well.
Thank you. That I definitely got drew the short straw on that one.
You had to do a lot of research, didn't you?
But it was good. It was enlightening. I tell you, I certainly have more respect for anybody that owns a trucking company now with all the regulations they have and things like that. But yeah, we've got a great lineup. We hope to see you guys there as well. So thank you again for spending an evening with us. You will be getting your CE, just like Guy said. Give us a couple of days. Don't forget to check your spam folder.
Yep, and if you anybody wants one of these Night Owl minis for the fast track calibration, there's where you can get them. 97, there's discounts if you order 10 or more. So it's the minihst.com site. And last thing is, this is our next webinar again. If you want that $20 off, go ahead and scan that code. You can also type in webinar or something like that if you want. I'm sure someone will contact you and give you that code. Did something and expanded my chat
You
box.
guys will get your CE at this point. You don't have to hang around. Guy, let's talk about the saliva real quick, since we never really got to that. But you guys will get your CE if you want to bug off here.
Yeah. And we don't have to go to the slides to talk to. I don't think so. If we talk about too much or too little, but yeah, we'll address that for whoever asked that question. I don't think we need the slides for it. I could back up if we wanted, but I think we'll do fine without them. What you want to talk about first, Rich? Too much or too little? Let's talk about too much. That's the easiest one.
Okay.
Too much. The answer is what we've already told you. It was pearl number, I think, 3. Give it time. That usually goes away. You get this new thing. Tell them they're going to get new. You're going to have saliva. My belief as why that happens is twofold. One, it's you got something new in your mouth. Your body thinks it's food. You start doing saliva. But I think probably more important than that, or more realistic, is we swallow a lot, and it's even when we're asleep, and that acrylic makes us have to change our swallowing pattern. And so you'll drool some at first, and so it takes 6 to 8 weeks for your body to retrain the tongue, assuming it's a device that does not restrict swallowing, because some of them make that a little harder. It will usually go away if it's too much saliva. Just give them 6 to 8 weeks, and the body will start learning that, hey, this isn't food, and it'll also learn how to swallow. If it continues on after 2 months, then there's probably something in that device design that's probably keeping them from swallowing while it's in place. So that's too much saliva. Do you have anything to add on that one?
Yeah, and what might that be? It might be thinning especially the upper lingual of the device. We like to thin it and scallop it so it feels as natural to the tongue as it can, because what happens when we swallow, our tongue goes up and forward, and I don't know that
it can also be the lower too. If the lower lingual flange is extended too far and they've got a real shallow floor of their mouth, they can't get their tongue up to swallow too. What you said is far more common, but I've actually had the lower be the problem, where that you just ask them to swallow with it in place is how you figure it out. And if they're having troubles, why can't they swallow? Go ahead. You were going to say something else. I
No,
apologize.
no, that's good. All that. I think it's, again, most of this as a dentist. You just got to kind of put your thinking cap on and think about this stuff as you do it. I think the too little saliva is probably the much more common problem. So, and in that, a lot of times it's the old, nose test. How well can you breathe through your nose? And I can tell you, after making, I don't know how many thousands of devices I've made, Guy, over the years, nasal patency is a big deal. If you want your devices to work better, then figure out how to get the patient's noses more clear. That should open up an enormous window of opportunity for you to refer to ENTs in your community. It really should, because it's so important. Because if I can't breathe through my nose and I'm a mouth breather, then I already have a dry mouth, so I'm probably not going to complain about it. But if I normally can breathe through my nose, and now my device is too thick top to bottom, and I can't get lip closure anymore, now I'm trying to breathe through my nose, but I can't. That patient is going to complain for sure. So we have the Somnofix tape. We can reduce the vertical where we try to get lip closure. You even talked about with TMD, reducing the vertical, Guy, too, as well. So sometimes the vertical helps treat the sleep apnea better, but remember that more vertical is more uncomfortable, certainly to your TMD.
Yeah. So I think one question you need to ask is, your mouth dry during the day too? So is this patient has Sjogren's syndrome? They're old and they have this anyway, and we just kind of made it worse, or is this really due to the device? And it can be. So lips closed, breathing through the nose is the goal, and that will help. So whatever you got to do, putting the elastics on the device, if it's a herps, a dorsal, things like that, whatever keeps their mouth shut, lips closed, breathing through the nose. Topical steroids. I'm a big believer in. A lot of my patients we have on Flonase every night, or Nasacort. It's not harmful, not Afrin. Don't go out and say, Guy said put everybody on Afrin. That's bad for you. But topical steroids are really good. Mouth shut, breathe through the nose is the goal. The other thing to mention is advancing the device can help, because you think about it. When you have apnea, what are you doing? When you move the jaw, when you have apnea, the air moves quicker, less air moves. Right? That dries the mouth out. It's like so when you get the apnea better treated, more air moves slower, and it doesn't dry the mouth out as much. So advancing the device, mouth shut, breathe through the nose is what you have to accomplish. And that's not always easy when you have someone like me. My mouth doesn't ever shut. Ask my wife, she'll tell you the same thing. When I have the short lip. And so for me, it may be hard. And I don't, Rich, you kind of glossed over that. The tape it can really work with some people. There's some, I forget the brands. What'd you say the brand was that you use?
Somnofix is the one that we like the best.
Somnofix. Okay.
And the other thing I want to mention too are the Xylamelts.
Yes.
So for people with really dry mouth already to start with, and then we exacerbate it a little bit, we order them off Amazon. We order Somnofix and Xylamelts off Amazon. So, we order probably $400 or $500 of that stuff. Seems like every couple of months, and we give it away. Maybe we should start charging for some of that stuff now. But those are two little tools. But again, you can't mouth tape somebody who can't breathe through their nose, unless you don't like them or they didn't pay their bill or whatever. Right. But right. Again, get their nose as clear as you can. And like Guy said, the nasal steroids, Guy, that's 50 micrograms of steroid per squirt.
Okay.
That's not very much. Think about a Medrol dose pack, where you take, 50 milligrams of it, the first day or whatever.
I'm not big on just, medicating people, but I tell you, that's been one of the single things that I've changed in the last 5 years that's made the biggest difference. Talk about the nose, and if they have any allergies at all, here in Florida, a lot of people do, put them on, have them do the nasal steroids. I've talked to at least a half dozen ENTs, and and other MDs as well, but at least a half dozen ENTs. Is there any negative effects that we need to be worried about these people doing Flonase? And I can't find any really significant issues as to why not to do that. That's why it's over the counter now. It used to be prescription. So, sure, ask them to clear up their doctor if you want to, but I'm very when in doubt, get them breathing through their nose and give them something like Flonase or Nasacort to
Yeah,
give them.
and Dr. Stan mentioned too the lip shield. So
Yeah, with tap,
airway,
yes.
airway management makes a little obturator. So it's like a very thin little piece of silicone that just goes underneath your lips. So it's like an internal mouth tape, so to speak. And that can be used well as well. And Debbie says mild OSA, somebody who's had buccal tissue radiation
Stuff.
and they're very tight, man. That's just difficult. If he can't get lip closure, even when a device isn't in there, he's certainly not going to get lip closure when you make a device. So you can make the thinnest device that you possibly can. You can, if they're not very strong, they're elderly. I love EMAs. Again, the insurance might be an issue there, but I can make an EMA out of 1.0 BioQuil. That's a really, really thin. The Panthera DSAD is a very thin device.
Yeah, I tell you another one. Actually, one of the first dentists who taught me to pay attention to the nose 10 years ago, Dr. Moses. They make the Moses device kind of a monoblock device, but don't discount it for that. Their whole point is you open the vertical with their shims until you can get them as open as you can, but keep their lips shut. And there's nothing on the front because it's basically just an Invisalign tray there in the front, the way that's designed. And that will work really, really, really well to get their lips around that. It's real smooth too on the buccal cheek. There's nothing moving or to pinch. And so for this patient, if they've got sensitive cheeks from the radiation, that might be a really good device as well, even though it's
Debbie, can you type in what type of device he has? So, a lot of times if they've had radiation on the buccal mucosa, a Herbst is not a good device for that patient.
No,
a tap might not be a good device. I mean, a dorsal might not be a good one.
A tap could be okay.
An EMA, tap makes more sense because I moved that adjustment, to the front. So maybe I can thin down the buccal, I can scallop it, I can do some of those things. And then time, when you say still having trouble wearing it all night, again, did you keep cool? Did you keep calm? I tell people it takes about 2 weeks. At 2 weeks, about 7 out of 10 of our patients can wear it through the night.
Mm-hmm.
That doesn't mean you're going to wear it tonight and everything's going to be great, So
I'm
says,
Sarah, to answer the question. I'm right now about 300 yards from the beach, and I'm about 60 feet from the intercoastal. So my house is on the intercoastal. I don't know. You never know. Give us a holler out. We're expanding our offices. We may need more help. She asked how far it was from the beach was the question there. So, and what else we got on here?
So Stan mentioned something about, older people having trouble with the sugar alcohols, and that's what the Xylamelts are. Yeah. I don't know, Stan, you're not supposed to eat them like candy, man. It's supposed to just help with your dry mouth.
Yeah, Debbie did put in it's a Herbst. So yeah, if someone's got buccal sensitive, dry mouth or, real that blistering inside of your cheek, think of finding something smoother to put in there would be.
Or maybe, like you said, you make him anything. A Medicare approved device too is the tap as well. So you can make him a tap that's just in the front. Now I'm going to make it a whole lot easier. The tap, you got to remember the tap family of devices. The Dream Tap is the newest. They made it difficult for all of us old timers because the plate was always backwards on the top, right? Adjusted, and now they put it on the bottom. So when it's on the top, it's righty tighty. But when it's on the bottom, it's the opposite way. So I do think that in that
someone typed in that trying to order a mini, some codes not accepted. This might have been an old slide. So if someone's trying to order a mini HST and you've got a code of some sort, you just email us. And we'll get you that right code. So here's our email again. I had it up the wrong way. Sorry.
Yeah, Daniel. So we'll make sure you get that discount. Absolutely. For doing that. Yeah. And again, Guy at the symposium is going to be talking about this fast track method. So, when I did this the old way, Guy, it was, hey, get your dental device. We'll see you in a month, and we titrate it. How you feeling? How you sleeping? So it was taking us 2, 3, 4 months sometimes to get to that target position. And Guy's going to talk about, with the advent of a home sleep test that's affordable, $100, stores 12 nights worth of data, we can now test multiple positions in a much faster way and do that. So, and Guy's going to give you a lot of the nuances that have to do with that. And, Guy, we're getting quite a bit of patient data on that at my office now.
Yeah.
With doing that. And I will tell you that just like we suspected, even when we titrate somebody slowly, you don't usually start to have issues with side effects until you get out to about 60, 70%, somewhere in there is where they start to kind of show up. But you can certainly do a fast track where you test somebody at 2, 3, 4, 5, 6, out of 10, and without hardly any side effects at all. But
we found you go back to about 7 most of the time.
Yeah.
I mean, we've done hundreds of these in our office. We were doing it before pulse oximeters, just the pulse oximeters were the limiting factor. And this new device has cut our post-treatment down from months to typically after the device is delivered, we make sure they're acclimated. So after the 3-week check, we can be finished about 70% of the time, if not a little bit greater than that, in 1 week. We at least know the target position. That's just incredible, because it used to take years ago 6 months.
Well, that too, Guy, in the first home sleep test unit I bought cost me $17,000 and only stored 8 hours worth of data. So,
right.
Debbie, I'm good on the tap. If you make a tap and you use either the Dream Tap or the Tap 3 Elite, those are the two that I like to use the most, have it made with Accutherm. So what that does, that's that thermocryl that we talked about, but they use a thinner layer of both the outer shell, which is a biocryl, and then the inner shell, which is the thermocryl type material. And I can make them smaller. And then when you put it on the lab slip too, if you're doing a Dream Tap, the adjustment plate's going to be on the bottom. Tell them you want to keep the vertical as absolutely to a minimum as you possibly can. So sometimes we would actually cut the plate off, take everything off, and literally set the plate right on the teeth, to keep the vertical as low as we can.
I want to address too what you said, Debbie, about, well, she's the youngest patient. I haven't been a big fan of these. I've had this discussion with my associate. We've got some really sleek, cool devices out there now. I mean, they're small, they're CAD CAM, they're printed, they're all this cool stuff. And they're a lot of them expensive too, but they're cool and people like them. But if all you had was a tap in your box, I can say I know a dentist that's on the ADSM blog all the time. All he uses is tap. He's treated thousands and thousands of patients. Most patients will be very happy to wear a tap. It goes back to some of our pearls going, hey, this is going to be good. You're going to get used to it. But if you go like, well, it's not as cool and sleek as the Prosomnus or the DSAT or the XYZ one of Tajur these days, then they're not going to like it. If all you had was a tap and the patient cares about it, they're going to get used to it. It's a very comfortable device once you get used to it. Maybe it's not as sleek in some ways, but its effectiveness is unquestioned. I think Rich and I, if we were having a AHI contest and we had a guy that had 75 AHI, and Rich and I are betting a new bass boat on who gets it lowered the most, well, he'd get a bass boat. I'd want a center console, but regardless of new boat, let's just say, and we said, all right, we're going to both treat this guy. I bet you we'd both stick him in a tap.
Certainly for something more severe. I don't exactly know what it is about, pulling from the center, as opposed to doing that. I certainly think it controls the vertical better. We're talking about, with Debbie's patient, trying to close down that vertical as much as we can. You might ask also, Debbie, for one of the lip obturators that we talked about. They actually make them to where they screw into the tap. You can actually screw them in through that. Lauren, I will tell you with the Dream Tap, you talk about it hitting in the back. Here's the deal with that. you know, when we take a bite, we take this tap gauge or pro gauge or George gauge, or I don't care which one you work, they all work, which one you use. And we look at, you know, we concentrate on the midlines and doing all that stuff. But a lot of times we don't leave enough room in the back. You know, we take a little piece of acrylic, we made a little boomerang out of it, and it's 4 millimeters thick. So when we put that 6 millimeter pro gauge, it's 6 in the front. The first thing that assistants taught to do is pull the cheek back and swipe that little 4 millimeter thick boomerang piece of acrylic through there. And if it hits, you got to go to the next one. You got to add more vertical. So I think that's a problem with a lot of people who make taps because they don't do that.
Well, what's happened is the Dream Tap, the hardware is thinner because it's on the lower, the way it works. And so you never had that problem with the Tap 3 Elite because the hardware, the way
Because you
it
had
works,
their mouth open 15 millimeters.
yeah,
Most of the time.
exactly. It
Yeah.
opened that mouth. It was almost impossible. So yes, if you were making the old Tap 3s and now you're having a problem with the Dream Taps, it's because they don't require as much vertical for the hardware, which is a good thing, but you just got to be cognizant of it. So, all right. And again, I know a lot of people signed off. That's fine. I think we're about done with the questions. You're going to get CE if you've left it. You know, you don't have to stay on, but I think we've got most of the questions. I hope you'll attend the next webinar. I'll throw that one back up one more time. This is going to be
I would say to Lauren too, Guy, you know, as you titrate forward, so that's what happens as you titrate the jaw forward, you know, that you do get more interference in the back. So you can shave down both the upper and the back. You know, we like to try to get posterior wrap of both the upper and lower arches because that helps keep us, especially if we have to get to a very protrusive position to treat, that helps keep us from developing contacts. We didn't get to talk about that one tonight, but you can, you know, taper that down. You can even cut that back tooth off if you want or something like that. All right, guys, sorry, I didn't mean to interrupt. That was the last one.
No, I think we're
going to do.
Everybody, and you didn't interrupt at all. Hey, I think it's been great. I like the new format. We'll just kind of, you know, let them to choose. We'll try to do that some more in the future on the appropriate subjects. If you want to know more about dental sleep and you're having challenges, that's what we do every day. Our whole team does. A lot of the questions you got answered here were from them as well. So thanks for attending. We hope to see you on the 27th or virtual course next week. I promise you, you'll say it was great use of 2 evenings of your time. And I think that's it. I don't see anything else. So sound good, Rich?
Awesome. Thanks again, Guy. Appreciate you putting that together. Thank you, guys.
All right, buddy. Good night, everybody.